good morning, everybody. Welcome to Surgery Grand Rounds. There is no commercial support for today's program. The speaker and planners have disclosed no relevant financial relationships with commercial interests. If you have a question for the presenter, please hold until the Q&A segment of the talk. If you're attending virtually, you may enter your question in the chat. A link to the event survey will be shared at the end of the program. If you are ABS certified and want NGHS to report your CME credits to ABS, please fill out the evaluation and give us permission to do so. And it is my pleasure to introduce today's guest speaker. Dr. Alec Seaton grew up in Cumming, Georgia. He attended Brigham Young University as an undergraduate, followed by medical school at the Medical College of Georgia. Next, he plans to practice general surgery in Valdosta, Georgia, after completion of his residency. Please join me in welcoming Dr. Alec Seaton.
So this whole process started for me last spring when Dr. Gibson asked me to present at the Robotics seminar here on the future of robotics in emergency general surgery. And then I ended up taking a job in Valdosta where they're kind of early on in their robotics development, and there's plenty of opportunity for the use of robotics. So I kind of tried to approach this with a non-biased, just kind of reviewing the data to see if it's something that I would want to participate in, because I'll be taking an ER call there. So we'll see how non-biased I can be. Disclosures, none. Too bad Garrett's not here. Maybe he could hook me up. But so learning objectives. We're going to talk about the advantages that the robotic platform offers in emergency surgery. We'll talk about the disadvantages of the robot in emergency surgery. And then we'll go through lots of the data that's come out fairly recently comparing outcomes as well as cost for using the robot in emergency surgery. So first, the growth of robotics. Emergency general surgery counts for about 4 million inpatient admissions every year. It's $28 billion in healthcare costs in just the United States alone. And emergency general surgery or acute care surgery is the fastest growing area of robotics in the surgery world. So this is from a study that we'll go through a little bit more later, but shows general trends of increased use of the robot since 2013, specifically in emergency general surgery. And notably, there's a kind of a takeoff point in 2016, which I talked to Dr. Stevens and looked up is actually when the XI, the Da Vinci XI came out. So what are the challenges of emergency surgery? Generally speaking, higher rates of morbidity and mortality and stoma formation compared to elective surgery. Tissues are inflamed and much more fragile. Less obvious planes to dissect through. Bowel, small bowel, and the colon can both be distended, make it hard for visualization. Difficult access. It's technically demanding and requires increased dexterity, precision, and stability to prevent harm to the patient. So how does the robot help meet these challenges? A big factor in that is visualization offered by the robotic camera. It's highly magnified. It's focus-free. You don't have to mess with the focus when it goes in. It's three-dimensional. It gives true depth perception while you're operating. And it's motion-free, which is a big factor. You don't have a resident with shaky hands holding the camera for you while you try to operate. And the other thing is it's surgeon controlled. Surgeon has total control of the camera. You don't constantly have to try to redirect your assistant to move or change the visualization so that you can operate. Firefly is another big factor. Firefly can be used to improve visualization of the vessels. You can find the bile ducts, which is probably the most common thing that we see in our residency for the use of ICG in general. You can use it for tissue perfusion. Most commonly, we use this for anastomoses to make sure they're well perfused and going to heal okay. But it can also be used in the cases of emergency surgery after a hernia reduction. You can give ICG and watch it with Firefly to make sure that that bowel is perfusing and doesn't need to be resected. Can also be used for identification of the ureters. I went to a robotic hernia course. Me and Dylan went 2 weeks ago, and they actually showed a video of doing a robotic gallbladder. It was at UAB, and kind of in the back in the cystic plate, you could see a little bit of ICG glowing, and didn't really think anything of it. But as they continued their dissection, it became pretty clear that it was the right hepatic duct. That would have been very easy to confuse for just kind of the part of the gallbladder. So it was kind of an interesting video. So the instruments eliminate the fulcrum effect that we see in laparoscopic surgery. So you move your hand to the left, the instrument moves to the left. Also in laparoscopic surgery, the length of the instrument combined with the fulcrum effect can increase tremor and increase movement of the instruments. They're wristed, which I think is one of the biggest advantages of using the robot. The rotation and movement of the robotic instruments is actually greater than the human hand. There's no tremor, which is helpful for me. It allows for working in smaller spaces, which is important for emergency surgeries. We talked about how distended the bowels can be. It requires less pulling of tissue towards the instruments, so less tension on the organs and structures, less tearing, less trauma. And it's more ergonomic, which the idea hopefully reduces injuries to the patient. It also allows for more non-traditional port placement. So you have more flexibility with where the ports go as opposed to laparoscopic surgery. This can be really important on patients who have a colostomy, or I did a laparoscopic cholecystectomy with Dr. Gibson on a patient who had an LVAD, trying to get the ports around the drive line. We ended up kind of operating like backwards with our left hand, and it made it pretty awkward. The staplers for the robot, the Da Vinci term is an optimized staple line. It monitors the compression during the firing of the stapler, which results in a more consistent staple line, constant compression and pressure throughout the firing. This results in less tissue trauma and damage. There's less stress on the tissue, and it can also be less traumatic to surrounding tissue. And there's less tip movement, which I think is important. As you kind of try to fire the stapler with your hand, you have to crank it. Every time you pull, you'll see the tip move just a little bit. It pulls on the tissue and can affect the staple line. And then the instruments also allow for stable retraction without an assistant. So you're not relying on somebody else to hold the gallbladder up or the colon. When you're doing a colon, you have complete control of all the arms and they're completely stable, no shaking. So in 2004, they actually did a study on suturing performance, robotic versus laparoscopic. I think this goes to prove that you can find a study on just about anything. But this is a study out of the UK. They asked 9 surgeons to place 3 sutures, laparoscopically and robotically. It was in a pretty early Da Vinci model. And then they measured the total time, the total instrument tip movement to complete the task, the number of fumbles of the needle, and the number of attempts it took to drive the needle through to complete the sutures, and then how many of the throws were loose, and number of inaccurate throws. So what they found, there's a 40% reduction in time to complete on the robot. There was a 70% reduction in total movement of the right hand, which for the total movement of the right hand was about 4,000 centimeters laparoscopically versus 1,000 centimeters robotically. There's a 55% reduction in total movement of the left hand, and it was 1.5 errors robotically versus 23 laparoscopically. So another potential advantage of the robot is the physical toll of surgery on the body. One article I found calls it an impending epidemic. Surgeons are known to be at increased risk for musculoskeletal disorders, as we have seen in our own program. So multiple studies have demonstrated up to 80% of surgeons experience musculoskeletal pain during and after cases. Studies demonstrated only 19% of surgeons reported injuries that led to over 40% work reduction in terms of operative volume for that surgeon. And this is important because there were estimates of a shortage of up to 33,000 surgeons in the United States by next year. So if we can reduce the toll and allow surgeons to continue to operate longer and avoid that 40% reduction in workload, it could make a drastic difference for patients. So there's a 2018 meta-analysis that was published in JAMA. It's subjective data, but a possible advantage for robotics. It was 5,828 surgeons, multiple surgical specialties. 20% complained of lumbar spine disease. 18% had been diagnosed with rotator cuff injuries. 10% had carpal tunnel. 60% complained of severe neck pain. 52% complained of severe shoulder pain. 50% with severe back pain. 35% upper extremity pain. And it actually compared these to other jobs, and the most comparable thing to surgery was construction labor. So in 2023, they took a survey of 150 surgeons, talking about laparoscopy versus robotics. 93% believe that Da Vinci system will extend their career because it reduces the toll on their body. We can't always blame surgery for all of our musculoskeletal pain. I have other reasons for back pain and neck pain. Another possible advantage of the robot is improvement in education. The teaching console is a big part of that. It allows you to record videos, something that we don't take advantage of much here. But there are places that record all their cases, and then they, like in M&M settings, they can actually review the video and kind of find what happened and why it happened, and with a live video, actually talk about how they could have prevented it. The arrows allow the surgeon to point better and actually show exact planes and those kinds of things to us as we learn. Also, the robot, with all the technology it has, will be more able to adapt with technologies that continue advances. I found that there's actually already early AI tech that they're working on to identify common bile ducts before they're injured and potentially actually stop the robot before it happens. And the other thing with Da Vinci is the app. You can actually kind of track things and get feedback on your efficiency and how much of the case you do versus the attending, and demonstrate improvement over time. So data for advantages of the robot in emergency general surgery, and we'll go through a lot of this data, but in general, there's data to support fewer blood transfusions and postoperative complications, reduced rates of 30-day mortality and readmission, and shorter hospital length of stay when comparing robotic surgery to laparoscopy. And then another big factor in emergency procedures is lots of studies have demonstrated a lower conversion to open rate in robotics versus laparoscopy. So we talked about the advantages. What are the disadvantages to using the robot in emergency surgery? Why aren't we just doing it for all of our cases now? There's logistical challenges. There's a lot more ORs than there are robots, and it takes extra training for the staff to be able to work with the robot. The stability of the patient in emergency surgeries can sometimes be a disadvantage for the robot over the laparoscope. Kind of talked about it, but availability of trained staff. If not everybody is trained, the people who are trained can't, be on call 24/7. So a potential disadvantage, a lot of times, the surgeon's operating on the console and can't necessarily see where the robotic arms are, and they're not necessarily aware. So there's potential for robotic arms to hit or pull things if we're not careful. And then the lack of haptic feedback. We talked about how fragile the tissues can be. Sometimes it's hard to fully be aware of how hard the robot is pulling on tissues, which could potentially increase trauma. So another big disadvantage is in the case of emergencies. The robot can be in the way. It can inhibit anesthesia access to the patient, and it can inhibit surgeon access to the patient. I've had 2 cases, both on different thoracic services, where got into bleeding on the robot, and it had to end up doing a thoracotomy to be able to stop the bleeding. Unfortunately, both patients did well, but the robot definitely became a challenge in that setting, as opposed to an advantage. If it had been laparoscopic, it would have been much faster and easier to pull ports and open the chest to stop the bleeding than it was to undock the robot or try to do a thoracotomy around the robot. Another disadvantage, and probably one of the biggest factors that people are using to decide, is the cost to benefit ratio, which is still unclear in this case. Reportedly, costs are about 25% greater for the robot versus the laparoscope. OR space, especially older ORs, are not always big enough to house a robot. And another thing is there's no universal credentialing to operate on the robot. We all go through FLS and courses to guarantee that we are capable with laparoscope. They actually do have a fundamentals of robotic surgery that's been validated by a multidisciplinary group. However, it's not required by any credentialing board of any of the surgical subspecialties. So instead, we rely on industry-sponsored courses that are sponsored by Da Vinci. There's a recent study, 42 hospitals reviewing their credentialing policies to use the robot, and the kind of comparing those to a lot of the high volume centers. They found that there's inadequate guidelines to necessarily ensure that surgeons are proficient before they're actually operating on the robot. So this is kind of the meat and potatoes of the presentation. We're going to talk about the outcomes of the studies that have been done. So we'll jump right into kind of the biggest and the well-known. This is a landmark study. There's actually a behind the knife journal review on it if anyone's interested. But it's a retrospective cohort study, like most have been. They did an analysis of the Medicare provider claims, analysis and review claims from 2010 to 2019. They only pulled the data on 24-hour observation or hospital admission patients, and then they used ICD-9 or 10 codes to identify the robotic procedures and complications. So their primary outcome was bile duct injuries that required reconstruction within 1 year after the original cholecystectomy. Secondary outcomes that they were looking at: overall incidence of complications within 30 days of surgery, bile duct injuries that didn't necessarily require reconstruction but required either a take back or a drain or other procedures. This was a study that included over 1 million cases. what they found over that course, 2010 to 2019, as we've shown before, the frequency of robotic-assisted cholecystectomy drastically increased. It actually increased 37-fold. It was 211 in this database in 2010, and then over 6,000 in 2019. Interestingly, in that same time period, the frequency of laparoscopic cholecystectomy also increased from 111,000, or the percentage increased from 75% to 77%. So the frequency of open procedures is what decreased drastically in that time period. So what they found in terms of the primary outcome, the bile duct injuries that required reconstruction within 1 year, in both arms, both robotic and laparoscopic, over that time frame, 2010 to 2019, the frequency of bile duct injuries decreased. For laparoscopy, it went from 0.3 to 0.1% in this study, and it went from 0.7 to 0.5% in the robotic arm. They found no difference in overall 30-day complication rate. However, it was a significant difference in the frequency of injury between increased frequency of injury requiring reconstruction in the robotic arm, and it was a significant finding. They acknowledge that there's a lot of bias in the way they did this study. Two ways you can think about it. A lot of surgeons who are well experienced tend to use the robot on a gallbladder that they feel like is going to be especially difficult. And then there's also the other side of that, where a lot of people who are just kind of picking up the robot probably picked the easier gallbladders to do it. So they weren't necessarily sure which way the bias was going to fall in this study. So they did this. They used the proportion. The year before the case, they looked at the proportion of cholecystectomies that were done robotically, and they tried to use that as a control. It's not necessarily a proven way to do it, but even after doing that, there was still, I'm going to talk about this. The difference remained there and was still statistically significant. So it was slightly lower after they did this comparison, but robotic was still almost twice as likely to have a bile duct injury as laparoscopy. So the top row of this here is where they did this comparison based on the previous year, the ratio of laparoscopic versus robotic cholecystectomy. But you can see here, there is a difference in every single case that they looked at. The risk of injury was higher in the robotic arm. So other things they found in this study, robotic cholecystectomy was more common in patients who had 2 or more comorbidities, in obese patients, in diabetics, and in elective cases, whereas laparoscopic cholecystectomy was more common in urgent or emergent cases or cholecystitis. And then the conclusion that they drew is the utility of robotic-assisted cholecystectomy should be reconsidered given the availability of an already minimally invasive, predictably safe laparoscopic approach. So general thoughts and criticisms that I found in reviewing other literature. They applied their study to all robotic and laparoscopic cholecystectomies, but the database they used included only 24-hour observation and admissions, which in cholecystectomy typically indicates that it was more of an emergent acute cholecystitis picture as opposed to a true outpatient elective cholecystectomy. Potential sources of error could be which surgeons are taking on more robotic cholecystectomies, whether that's new surgeons straight out of residency versus older surgeons who've been doing laparoscopy for a long time. We're unsure of how this instrumental variable analysis really controlled for those different confounding factors. Also, when laparoscopy first came out, the studies I found from the early 90s when it was kind of starting estimated the rate of common bile duct injury as high as 3%. So that shows that over time, as we improve our abilities, this becomes a more infrequent complication. But the question that this study brings up is it okay for us to go through that same process when we already have a minimally invasive procedure without clear differences in patient outcomes to support the use of the robot? There's actually a video that's published of a surgeon who cut a common bile duct in the surgery, and then they kind of talk about what happened, and what they found is the port that they use the camera for in a robotic cholecystectomy is not generally in the same place as a laparoscopic cholecystectomy. And as the surgeon was retracting, he felt like he was looking at the same view as he would have laparoscopically. But the difference of the camera and angle, everything, he was actually pulling so that it perfectly aligned the cystic duct with the common bile duct. And that's how it happened. So kind of learning the difference between the view of a robotic cholecystectomy and a laparoscopic cholecystectomy was a big part of that. So this was another study, came out in JAMA this year. Is another retrospective cohort study. I found most of these studies coming out right now are all retrospective cohort studies that just use different databases for their data and kind of focus on different procedures. This was specific to emergent cholecystectomy and was designed to emergent cases and was meant to be about emergency use of the robot. They looked at cholecystectomy, colectomy, and then inguinal and ventral hernia repairs. They also had over 1 million patients that they looked at. They defined emergent as life-threatening or potentially disabling, and they defined urgent as patients that required immediate attention whose care was prioritized as first available, which could be a bias in and of itself, as we all see sometimes you post a case as a level 2, so that it bumps the case in front of you, when really it doesn't necessarily have to go emergently. So what they found were robotic patients were more likely to be older, obese, have more comorbid conditions, and in the South. So shout out to that Southern diet and our obesity rates. But these are their findings. They found that there was a lower risk of conversion to open in each procedure. There is a decreased overall length of stay for the inguinal hernia and the colectomy arm, and decreased post-op length of stay for all 3 cases except for cholecystectomy. So again, there's lots of bias introduced into this because there's no way to control why these cases were chosen laparoscopically versus robotically. Were they picking the easier hernias to do robotically? We don't know. This was an older study from 2019. It's a smaller study, but it was looking at robotics for urgent subtotal colectomies in patients with ulcerative colitis. It was only 19 patients. What they found, robotic surgery took 29 minutes longer. No significant difference in blood loss between either group. They found 6 post-operative complications in the laparoscopic group and only 1 in the robotic group. 2 laparoscopic patients required reoperation versus 0 robotic patients. And then the robotic group, they found had earlier return of bowel function, shorter length of stay than the laparoscopic group, but these were not statistically significant. What they defined as complication, the one complication for the robot group was an ileus. The complications for the laparoscopic group, one had an abscess, the two that required reoperation, two had an ileus, one had urinary retention, and one had a pneumonia. And then their reoperations, one was for an ischemic ileostomy, and the other one was for obstruction of the ileostomy at the level of the fascia. So there's another retrospective study, 2008 to 2020, from a different database. This looked at emergency surgery operations, including appendectomy, cholecystectomy, bowel resection, perforated ulcer repair, and lysis of adhesions. They estimate that these procedures account for 80% of emergency general surgery in the United States. So what they were mainly looking at was in-hospital mortality, but secondary outcomes that they measured were hospitalization cost, postoperative length of stay, and then major complications, and then blood transfusions. This was a study, this included over 4 million patients. 98% of them were laparoscopic versus less than 2% robotic. Their demographics, they found that patients receiving robotic surgery tended to be older, have more comorbid conditions. And this is what they found. Compared to laparoscopic surgery, there's a 2.2% reduction in overall complications, as well as a 1-day decrease in the length of stay across all procedures. The robotic group demonstrated decreased complication rates and decreased length of stay. Overall in-hospital mortality, which was their primary outcome, had no significant difference. They did find that robotic had a decreased rate of major complications after large bowel resection. And then another major finding of this is blood transfusions were reduced in the robotic arm for large bowel resection as well as cholecystectomy. So they found that the use of the robot over their time period increased for all of the procedures. The greatest change they saw was for colectomy and repair of perforated ulcers. This was another study. This one came out last year out of Florida. This was just a 2-year study, but again, defined emergency general surgery by ICD-10 codes. It was a 60,000 patient study. Only 3,700 were robotic. In the appendectomy arm, they found no difference in length of stay, no difference in complications, no difference in mortality. They did find that more robotic patients ended up having an ICU admission. In the cholecystectomy arm, they found no difference in ICU admission, no difference in mortality. Overall complications, less complications in the robotic arm. They did not define what they categorized as complications. They found no difference in length of stay. In inguinal hernias, no difference in length of stay, no difference in complications, no difference in mortality. Less robotic patients required ICU admission after inguinal hernia. And ventral hernias, no difference in length of stay, no difference in complications, no difference in mortality. Less patients required ICU admission. This was a retrospective single institution review, and it just shows that this was specific to emergency surgery as well. In each case, the use of the robot drastically decreased the rate of conversion to open. So we talked about how cost is one of the major factors preventing the wider adoption of the robot in emergency surgery. So what are those cost differences? It's challenging to measure. Also, quality of life of the patient is a major factor that you can't really account for in those studies. Most studies will find that the robotic surgery has higher costs than laparoscopy. And those can be due to the cost of the robot itself, maintaining the robot, the disposable materials of the robot, and longer operative times. This was a study, a retrospective study from 2019. They used ICD-9 codes for laparoscopic and robotic cholecystectomy, ventral hernia repair, right and left hemicolectomy, sigmoidectomy, APR, and then total abdominal hysterectomy. And then they use this method to try to help estimate cost, and then they controlled for several factors. Their N was 91,000. These were the differences that they found. So cholecystectomy was $9,618 laparoscopic versus $10,944 robotic. That was a 13.8% increase. Ventral hernia was $10,739 versus $13,441, which was a 25% increase. Right colectomy had a 20% increase. Left colectomy had a 23% increase. Sigmoid colectomy had a 23% increase. So on average, the cost of a robot $1.5 to $2 million. Plus, that does not include maintenance costs, training staff, or the time for surgeons to learn on it. Many instruments are limited use that can add to the cost. They did find that length of stay was shorter for robotic versus laparoscopic cases, which is important because it suggests that despite the decrease in length of stay, that decrease is not enough to make up for the increased cost of using the robot. Interestingly, hysterectomy had the lowest increased cost and was the only procedure that was performed more frequently robotically, which can suggest that you can offset the cost difference with more experience. So the more you do a procedure, the more efficient you can get and actually decrease the cost. Earlier reports, this one was from 2019, but earlier in the 2000s, they did a similar study that actually showed much higher costs of robotic versus laparoscopic hysterectomy. So that just shows that the cost has drastically decreased as it's become more frequent. So there's a learning curve. It takes a lot of cases to become proficient on the robot. This is also applies to staff. Staff pulling extra instruments, handling problems with the robot that can increase operative time. Those are all improved with more experience. We talked about this already. This is the same study we looked at earlier. We didn't talk about the cost arm of it though. Robotic procedures had consistently higher hospitalization costs compared to laparoscopic. The widest was in cholecystectomy, which was a disparity of over $5,000. And it was a significant difference in each arm. So again, more comorbidities on the robotic arm. And then the 1 day reduction in length of stay did not have as much of a cost difference of using the robot. And this actually showed that the cost difference, they compared the cost difference in 2012 to the cost difference in 2019, and the gap was actually wider in 2019. So again, this is another study that we didn't talk about the cost arm, but shows statistically significant differences in cost of robotic versus laparoscopic appendectomy, cholecystectomy, inguinal hernia, and ventral hernia. And then they broke down the cost by year, and for all years and all procedures, robotic was more expensive than laparoscopic in total surgical costs. This is a study they did on cost in robotic assisted thoracoscopic surgery, just kind of showing the same trend that in general, as the frequency of a case increases, the cost per procedure actually decreases as we become more efficient. It does kind of show a gradual increase after a certain point with increased, and the explanation for that is that as you become a kind of a center of care for that case, you tend to get the more complicated cases sent to you from other hospitals. So how can we reduce the cost of robotic surgery? You can increase the number of cases so that each case costs less. That would be increasing surgeons or becoming more efficient. So decreasing turnover time, increasing our ability to problem solve when there's errors with the robot, and improving procedure flow. And then also with increased proficiency, we can require less equipment. We don't need as many instruments, and less opening of instruments that aren't necessary. So things that I thought about as I was going through these studies, I couldn't find any prospective or randomized studies, nothing to control for those confounding factors. ICD-10 codes are often not reflective of their true case. A lot of times we get patients that we think are symptomatic cholelithiasis, and then in the actual surgery, it's pretty clearly acute cholecystitis. We've talked about the robot is often used in cases felt like are more difficult or more likely to open. And then cholecystectomy especially is often used as a training case in lots of the subspecialties of general surgery. So I did find that there is one ongoing study. It's the ROAM study. It's a prospective study from 50 centers worldwide, focusing on emergency robotic versus laparoscopic surgery for diverticulitis, cholecystitis, and obstructing hernias. And this is straight from their paper, but the primary aim is to evaluate safety and feasibility of robotic surgery in patients requiring emergency treatment for those conditions. And then secondary aim is a cost analysis. So in 2023, the World Society of Emergency Surgery actually came out with a position statement, several position statements. They're very cautious in general about using the robot in emergency surgery, but say that in emergency surgery, robotic surgery is very dependent on surgeons' experience and should only be performed in appropriately equipped operating rooms with trained nursing staff. Robotic surgery in emergency settings may be considered in highly selected, clinically stable patients only. Robotic surgery may be considered in challenging situations which are foreseen as a reason for conversion to open surgery if operating in laparoscopy. The use of robotic surgery for unscheduled and urgent operations needs to be implanted without creating scheduling conflicts in the occupation of the operating room. Moreover, the increased costs need to be justified in the context of an efficient implementation of robotic surgery. Currently, the availability and accessibility of the robotic platforms for emergency care surgical units are very limited. So basically indicating to decrease the cost, they don't want emergency surgeries bumping elective robotic surgeries. So the conclusions that I came to, a lot more data is needed to fully assess the use of the robot in emergency surgery. We need randomized trials and prospective trials. A lot of the available data is conflicting. Have to assess the value to the patient versus the value to the hospital versus the value to the surgeon. Those are all factors in making this decision. The most universally, I would say, positive things of using the robot in the surgery is decreased risk of bleeding and opening. So I think it's fair to consider strongly the use of the robot in cases that we feel are at increased risk of bleeding or increased risk of conversion to open. Patient selection is extremely important. I don't think that we should blanket say all emergency general surgery should be robotic or no general surgery should be robotic. I think it's very dependent on each case, as well as the hospital scenario. Here we're lucky where we have 24-hour access to the robot with trained staff. So those are all things to consider. Here's my references. Let's say thank you and special thanks to Dr. Stevens for his help with this.
Good morning. Thank you for presenting. Was the data on cholecystectomies all emergency robotic cholecystectomies or all comers?
So that first study, the one that came out of the University of Michigan was it was meant to be all cholecystectomies, but that's the database that they used only included patients that were either observed for 24 hours or admitted to the hospital. So they applied it to all cholecystectomies, but I'm not sure that that's necessarily fair.
Okay. This may be a pointy question. Bile duct injury, as rare as it is, it's actually rather common in terms of the numerical number of events that take place, just because of the sheer number of cholecystectomies we perform. And it is also one of the most litigious cases across the country. When we have data like you presented, where it says you have 2 times the risk of bile duct injury, why perform robotic cholecystectomies?
So I think especially in cholecystectomy, we need to be very particular about the patients that we pick for robotic cholecystectomy, as well as acknowledge our own experience on the robot when selecting those patients. But I do think that decreasing the chance of having to open or the blood loss in selective patients would be an advantage to using the robot for cholecystectomy, especially with a surgeon who's experienced with the procedure.
I can see how you're leaning on some of the evidence to make that statement. And I'm just going to voice my opinion here and present an air of caution. In cases of litigation, lawyers will tend to lean on very well published articles. Even experts who they hire will tend to lean on very well published articles. And it'll be hard to defend oneself when there is a World Journal of Emergency Surgery saying be cautious and another journal saying there's twice the risk. I'm just saying that for all of our trainees to be safe, because as long as you have that, it will be hard for you to save yourself in such a situation. I pray that that never comes to be.
Okay, very well. Thank you so much, Dr. Seaton.